Good morning everyone, and I welcome you to this introductory lecture on congenital heart diseases. My name is Dr. Sagar Sahita. I'm an assistant professor in the Department of Cardiothoracic Vascular Surgery at Unmicrc Institute of Cardiology and Research Center, Ahmedabad. The spectrum of congenital heart diseases is so wide, and the pathophysiology can be sometimes very daunting to understand. In the further lectures, our faculty will be discussing each and every lesion in much more detail. But an introductory lecture delineating the basic pathophysiological mechanisms of these lesions seemed appropriate to begin with. What I'm going to say today is nothing new. The fathers of pediatric cardiology have already described everything in their exhaustive textbooks. So these are my references for today's talk. The fetus is living in a very different environment in the mother's womb. It is important for the pediatric cardiologist and pediatric cardiac surgeon to understand the important aspects of the fetal circulation and the changes that occur at birth, the transition from the fetus to the adult. This can help us understand the various clinical features of the different congenital heart diseases. So we all know the basic pathway of blood flow. The deoxygenated blood comes from the SVC and IVC and goes to the lungs for oxygenation. The oxygenated blood comes back from the lungs via the pulmonary veins into the left atrium, and it is supplied through the aorta to the rest of the body. But in the fetus, the placenta is the source for all the nutrients and the oxygenated blood. The oxygenated blood comes via the umbilical veins and via the ductus venosus joins the IVC. This is the first thing which is peculiar about the fetal circulation, the ductus venosus. Now the blood in the IVC, which is coming from the lower body, deoxygenated blood, and oxygenated blood coming from the placenta, don't mix. This is a very unique thing about the fetal circulation. Rather, they flow in two differential laminar streams at different velocities, and they have different destinations. Let's see. If you see, the portal vein and the IVC have deoxygenated blood. The portal vein blood goes to the right lobe of liver, and some of it comes and joins the ductus venosus. The ductus venosus, through the ductus venosus, the oxygenated blood from the umbilical vein enters the IVC. As I said before, these two streams are separate. The IVC deoxygenated blood joins the SVC deoxygenated blood and through the tricuspid valve enters the right ventricle. But the oxygenated blood is, by a special mechanism, pushed directly into the LA through the foramen ovale, and through the LA enters the LV. This is the unique feature about the fetal circulation. Here we can see in much more detail the oxygenated blood coming from the placenta, traveling in the SVC through the foramen ovale to the left side of the heart to the aorta. If you notice here, the IVC deoxygenated blood goes through the pulmonary arteries and through the ductus arteriosus, which is open, and mixes with this oxygenated stream, so that the blood in the descending thoracic aorta is a mixture of the more oxygenated umbilical vein blood and the less oxygenated IVC blood. So essentially what is happening here is good oxygenated blood is going to the brain, and also if you notice here, the coronary arteries supplying the myocardium and the upper limb. So good growth, development, maturation of the brain and the myocardium. with good oxygenated blood. Relatively deoxygenated blood in the DTA, supplying rest of the body. You may ask what is happening in the lungs. In the lungs of the fetus, 10 to 15% of the cardiac output is going, but the alveoli sacs are filled with water, and because of the low oxygen tension, there is a lot of active pulmonary vasoconstriction. So the pulmonary vascular resistance is very high and not much blood is flowing into the lungs, not much oxygenation is taking place in the lungs. All this is about to change at birth. Let's see how. So because of his extensive studies in fetal lambs, Professor Abraham Rudolph gave us this diagram. You can see placental high saturation, 85% oxygen saturation blood going through this special mechanism through the IVC directly into the left atrium and in the ascending aorta, from where it supplies the brain and the heart, and the rest of the body receiving a relatively deoxygenated 55% oxygen saturation blood. At birth, what happens? The placenta umbilical cord is going to be clamped. The placenta was the region with a very low vascular resistance. So for the fetus, systemic vascular resistance was very low till now. As soon as we have clamped the aorta, the systemic vascular resistance has gone up. The ductus venosus closes because blood stops coming in from the placenta. Because systemic vascular resistance is very high, the left-sided pressures go up. The foramen ovale also closes. Most important event which is occurring is actually lung expands with the first cry. So the alveoli which were filled with blood suddenly are now filled with air. The child takes in the first breath of air. Oxygen enters the lungs. Because of oxygen, now there is pulmonary arteriolar vasodilation also. And the pulmonary vascular resistance, which was so high in the fetus, now suddenly starts falling. Drastically falls, in fact, so that more blood is entering the lungs for oxygenation. This is the ductus arteriosus. As soon as oxygen tension rises, there is active constriction of the smooth muscles in the wall of the ductus arteriosus, and physiological closure normally takes place within the first 24 hours itself. So as you see, before birth, the right and the left sides of the heart had almost equal pressures, and the pulmonary vascular resistance was almost equal to the systemic vascular resistance. The changes would take place at birth with closure of the ductus venosus, expansion of the lungs, closure of the foramen ovale, closure of the ductus arteriosus. The fetal circulation starts transitioning into the adult circulation. If you notice in the adult, the pulmonary vascular resistance is very low. Systemic vascular resistance is almost 20 times that of the pulmonary vascular resistance. There is no shunting at any level in the adult heart. The left-sided pressures are higher than the right-sided pressures. So this transition from birth to adult takes time. It doesn't happen suddenly. The pulmonary vascular resistance falls drastically at birth, but keeps changing even after that for a few years. So the pulmonary vascular resistance falls drastically at birth. Still, it is not at the adult level. We already described the changes happening which cause the pulmonary vascular resistance to fall at birth. After birth, it slowly reaches adult level, close to the adult level by 8 weeks of life. What happens in these 8 weeks is the thick musculature around the pulmonary arterioles starts thinning out. And beyond the first year of life also, pulmonary vascular resistance still keeps falling. This fall is because of increase in the number of alveoli in the lungs. So at three levels, three different phases, the pulmonary vascular resistance is falling. If the pressure in the right side and left side of the heart are the same, no shunting is going to occur, right? But as the pulmonary vascular resistance reaches close to the adult level by 7 to 8 weeks of life, the right side pressures are very low, and that is when the left to right side shunting starts. That is when they start clinically manifesting. That is when the clinical features start emerging. For example, a patient with a ventricular septal defect will not be symptomatic at birth, but as his pulmonary vascular resistance falls, the left to right shunting will start, and the child will present with congestive cardiac failure around 6 to 8 weeks of life. Another point to add at this stage would be, for preterms, this musculature of the pulmonary arterioles is already not as well developed. So their pulmonary vascular resistance falls faster than term neonates. So rather than presenting with congestive cardiac failure, a patient with VSD and a preterm would present earlier, as the pulmonary vascular resistance would fall faster in these babies. So in the normal heart, if you see, the right-sided pressures are lower than the left-sided pressures. Left-sided saturation is higher than the right-side saturation, and there is no change in the saturation in the right side and the left side. That is, there is no shunting at any level. So you see that every child with congenital heart disease need not necessarily have symptoms at birth. As the child grows older, the symptoms start to emerge. Professor Dr. Alexander Nadas described his criteria. So if you find a symptomatic child, how do you diagnose that the patient is probably having a congenital heart disease? As per Nadas criteria, if one major or two minor criteria are present, his child is most likely having congenital heart disease. The major criteria are systolic murmurs of grade 3 or more. Any diastolic murmur is pathological and a major criteria. Cyanosis and signs of congestive heart failure. In the minor criteria are the flow murmurs, that is systolic murmur less than 2 or lesser, an abnormal S2 heart sound, an abnormal chest X-ray, abnormal ECG, and an abnormal blood pressure. A good history goes a long way in helping you diagnose a child with congenital heart disease. Gestational history is important. A mother who has had a rubella infection, for example, has high likelihood of cataract, deafness, and patent ductus arteriosus in their child. Infants to diabetic mothers are more likely to develop transposition of great arteries. Lithium has been linked to Epstein's anomaly, and retinoic acid to conotruncal abnormalities. Family history is also important. A sibling having a history of heart disease puts you at increased risk, like we see in hypoplastic left heart syndrome, where the increased risk is up to 10%. Mothers who have congenital heart disease tend to put their children at 15 times more risk of having CHD. Postnatal history is also important because children can rarely explain their symptoms to us. Mostly we get to know by poor weight gain and poor increase in height. Children who are in failure cannot even generate a proper cardiac output to help them feed. Generally, small babies will tend to feed every 2 to 3 hours, but children who are in failure will demonstrate a typical suck rest suck cycle, where during feeding they start having a cold sweat on their forehead and they stop feeding, and then they have to rest for some time, and then they again start feeding, and this cycle goes on and on. A child having a cyanotic spell is a definite pointer to that child having congenital heart disease. Mostly spells occur in tetralogy of Fallot, but they can occur in other conditions with Fallot physiology. Finally, syncope, chest pain and palpitations are also some common complaints which we get to see in older children. As far as clinical examination is concerned, on inspection, we should try to see whether there are any obvious signs of other congenital abnormalities or congestive cardiac failure or clubbing. We should note the height and weight because usually children with congenital heart disease have less height and weight compared to other children their age. Children with left to right shunt in congestive cardiac failure have normal birth weights, but after that, due to congestive cardiac failure or suck rest suck cycles, inadequate feeding, they do not have proper weight gain. And cyanotic children tend to have less skeletal growth also, so their height is also less. Other congenital abnormalities like Down syndrome patients usually have atrioventricular septal defects. Bacterial abnormality patients usually have congenital heart disease. Patients with DiGeorge syndrome are more prone to have interrupted aortic arch and other conotruncal abnormalities. So we should always look for some typical syndromic children. The respiratory rate will be high in children with CCF, and normally anything above 50 is abnormal. A child when he is born is having a heart rate close to 40, and then as they grow it becomes lower and lower. Older children will tend to have Harrison's sulcus or Harrison's grooves because of increased effort of respiration. Saturation and blood pressure should be measured in all four limbs in congenital heart disease patients, because patients with coarctation of aorta will have feeble pulses in the lower extremities. They will have less blood pressure in the lower extremities. Saturation may differ in all the extremities, something called differential cyanosis. So this is very characteristic of a patent ductus arteriosus in which there is now severe pulmonary hypertension and the shunt is actually right to left. So desaturated blood is flowing through the ductus into the aorta. In that case, upper body will have normal saturation, lower body will have desaturated blood. The opposite of this can happen, reverse differential cyanosis can happen. If this happens in a transposition physiology, the upper body will have desaturated blood and the lower body will have a saturated blood. So, palpation and auscultation. So at birth, if you are hearing a murmur, if you are having findings, it's mostly a regurgitant or an obstructive lesion. And at birth, usually left to right shunts will not manifest. They will manifest 6 to 8 weeks after birth. Once the clinical examination is done, auscultation I think is the most important, and an auscultation will tell you whether it's you're hearing the characteristic ejection systolic murmur of an aortic valve stenosis or of a pulmonic valve stenosis or a continuous murmur of a patent ductus arteriosus or a pansystolic murmur of a ventricular septal defect or mitral regurgitation. Once you have an idea in your head about the provisional diagnosis, the chest X-ray will help you decide various things. Like the situs, for example, you can decide from a chest X-ray which chamber is enlarged, the right atrium, right ventricle, aorta, pulmonary artery, and also whether you are dealing with a high QP lesion. QP is pulmonary blood flow, or a low QP lesion. So are you dealing with plethoric lung fields or are you dealing with oligemic lung fields? This is the most important distinction to make on a chest X-ray. And finally, a good ECG will really clench the diagnosis for you, because if you can find out the axis deviation and which chambers are enlarged or hypertrophied on an ECG, along with additional information about characteristic conduction abnormalities, then we are really close to the answer. If we have done our clinical examination accurately and with the help of chest x-ray, ECG, auscultation, we can come 99% of the cases we can find out the diagnosis. But echocardiography really is what is essential to correctly delineate the entire problem before taking up the patient for surgery. A good echocardiography by an experienced pediatric cardiologist is every pediatric cardiac surgeon's dream. And now a good echocardiography really has replaced the need for CTPA or MRI or cath in most instances. Good echocardiography is enough. Having said that, it is good to know how to clinically come to a diagnosis also, so that you can correlate. If some findings are not matching, you can appropriately order the CT scan or the MRI for such patients before taking them to the theater. So broadly, we can clinically say that there are three types of congenital heart diseases: the left to right shunts, the obstructive and the regurgitant lesions, and the cyanotic lesions. Let us see them one by one. So in the left to right shunts category will come the atrial septal defects, the ventricular septal defects, the atrioventricular septal defects, and patent ductus arteriosus. So we'll be using this diagram to understand mainly. This is the normal heart. You can see that the blood is flowing through the vena cava. One arrow, all the chambers same size, no shunting. So each arrow delineates a particular amount of blood. So in a normal heart, QP is always equal to QS. Amount of blood flowing both sides of the heart is the same. So what happens in an atrial septal defect? Across the interatrial septum, blood is shifted left to right. So more blood in RA, more in RV, more in PA. So the chambers enlarged are actually RA, RV and PA, as we can see on this X-ray. RV type of apex and prominent pulmonary artery. The direction of the shunt is left to right because of the relative compliance of both the ventricles. So the RV is more compliant than the LV. And if you notice in an ASD, there is no direct transmission of systemic pressure to the PA. So children with atrial septal defect rarely ever develop signs of congestive heart failure. Usually you will find them asymptomatic till 4 to 5 years of age. Children with atrial septal defect don't really have much signs or symptoms. We can hear a wide and fixed split S2, which is characteristic of an atrial septal defect. And also the crocketate sign or the RSR- pattern in the right precordial leads is also characteristic of an atrial septal defect. So what happens in a VHD is left to right shunt across the VHD. So blood enters from LV to the PA. More blood returning to the left side of the heart, LA enlargement, LV enlargement. Typically these patients have a small aorta and a large PA with plethoric lung fields. And on the X-ray, in contrast to an ASD, you will find a LV type of an apex and plethoric lung fields. On auscultation, a very characteristic feature of ventricular septal defect is the murmur. Pansystolic murmurs are heard only in ventricular septal defects, mitral regurgitation and tricuspid regurgitations. And a very large VHD will give rise to equiphasic complexes of biventricular hypertrophy in V3, V4, V5 and also signs of volume overload. We can see the Q waves in V5, V6. In an atrioventricular septal defect, if it is just an ostium primum defect, it behaves like a simple ASD. But if it is a complete AVCD, it has features of both ASD and VHD. That means all the chambers are enlarged. There is high blood flow through the pulmonary system. This can lead to early congestive cardiac failure, early severe obstructive PAH, and on ECG you can find the characteristic extreme northwest axis deviation in these patients. In a patent ductus arteriosus, blood is shunted from the high pressure systemic circulation into the PA across the ductus arteriosus. So more blood returns to the left side of the heart and even the aorta and enters the PA. This is the distinguishing feature, that left side of the heart and the aorta are all enlarged in a patent ductus arteriosus, and also direct transmission of the systemic pressure into the PA. This leads to early development of CCF and also obstructive pulmonary arterial hypertension. If you see this X-ray, you see a extremely plethoric lung field, enlarged pulmonary trunk, LV type of apex, and also an enlarged right pulmonary artery. So what clinches the diagnosis in a patent ductus arteriosus on auscultation is the continuous machinery murmur that you hear, because between the aorta and the pulmonary artery, both during systole and diastole, there is a gradient between aorta and pulmonary artery. So the murmur occurs throughout the cardiac cycle, and this is the most characteristic feature of a patent ductus arteriosus. The second group of congenital heart defects are the obstructive or regurgitant lesions. So these lesions will give signs and symptoms at birth only if they are critical, like aortic stenosis or pulmonic stenosis, coarctation of aorta, mitral stenosis, tricuspid stenosis very rarely, aortic regurgitation, mitral regurgitation, tricuspid regurgitation or pulmonary regurgitation. We'll see the most common ones. In aortic stenosis, so all the obstructive lesions are having three characteristic features. One, you will hear a systolic murmur. Second, the chamber which is ejecting against this stenosis will develop ventricular hypertrophy. You will be able to see this on a ECG. And post-stenotic dilatation, which is not usually occurring in subvalvular stenosis. This is a feature specific of valvular stenosis. And as the severity of stenosis increases, the intensity of the murmur also increases. In coarctation of aorta, if it is a simple coarctation of aorta, because of this pressure gradient, it leads to development of collaterals. So the child grows normally also most of the time, because good collaterals develop and supply the lower half or the post-stenotic site. But in spite of that, the pulse is weaker in the lower limbs compared to the upper limbs. This is a characteristic feature of coarctation of aorta. If during childhood there are associated lesions like a VHD, for example, so this will lead to shunting of blood left to right, as we had seen previously. This further reduces the amount of blood flow through the ascending aorta and coarctation site. As we know, it's a rule of nature, no flow leads to no grow. So these patients are having critical stenosis of maybe aortic valve, ascending aorta, associated lesions, and that's why these patients become symptomatic much quicker rather than other patients who survive even into adulthood and develop collaterals. Sometimes you will hear in the interscapular regions of those adult coarctation patients even continuous murmurs of the collaterals. In this X-ray, we can see the characteristic reverse 3 sign of a coarctation. But more important than that, even if that is absent, whenever on an X-ray you find notching of the ribs, you have to suspect it is a patient of coarctation who has survived into adulthood, because these are notchings on the undersurface of the ribs created by the intercostal arteries which have dilated. As far as a pure pulmonic stenosis is concerned, it's same as aortic stenosis. You can see on the ECG right side RVH, and as the severity increases, the ejection systolic murmur intensity also increases. If critical pulmonary stenosis is present and there is an interatrial communication, there will be right to left shunt, and then that critical PS is the cyanotic heart disease. Another thing to note is that in simple PS, when the severity increases, the severity of the murmur also increases. This is in contrast to tetralogy, which also has pulmonary stenosis. But in tetralogy, when the severity of PS increases, the murmur diminishes. Having said that, let's come to the last group of patients, that is the cyanotic lesions. The typical example of a cyanotic lesion is tetralogy of FALLOT. But you can remember all the T's: transposition of great arteries, total anomalous pulmonary venous return, tricuspid atresia, and truncus arteriosus. This is the characteristic boot-shaped heart of a tetralogy. So in tetralogy, four things: an unrestricted VSD, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. What we need to know is this unrestricted VSD, there is no shunting between RV-LV. The shunting is directly from RV to the aorta, and the right to left shunt depends on systemic vascular resistance and pulmonary vascular resistance. So there is PS, less blood flow already into the lungs. When a child goes into a spell, when the systemic vascular resistance falls and right to left shunt increases, blood flow to the PA reduces, less oxygenation happens, and cyanosis exacerbates. In this case, you can see saturation is 94. That means this is mild PS, blood flow in the lungs exists, oxygenation is taking place, and the murmur which you will hear in tetralogy is ejection systolic murmur of PS. In mild PS, there is still blood flow through the pulmonary valve and you will hear a loud murmur. On the other hand, if the PS is extremely severe, less blood flow through the lungs, less intensity of the murmur, less oxygenation happening, and saturation is very low. So this is severe PS in a case of tetralogy. Coming to transposition of great arteries, normally in the adult, the blood circulation are in series. In transposition, they are in parallel. The blood in the right side goes to the body, comes back to the right side. The blood on the left side of the heart goes to the lungs, comes on the left side. So you may ask, how do these kids survive? It is because of some form of shunt or mixing at some level, either an ASD, a VSD, or a PDA, which allows for mixing. In transposition of great arteries, here you can see that once the child is born, pulmonary vascular resistance falls and more blood flow from the LV to the PA and more blood entering the left side of the heart. Very little blood is oxygenated blood is flowing to the right side of the heart and into the systemic saturation. Systemic saturation only 45. So there is inadequate or poor mixing in these cases. This child will develop shock, hypoxia, acidosis very soon. So what we do in these children is usually a balloon atrial septostomy. So kids with transposition who have a large unrestricted ASD allows for good mixing of the blood. You can see the saturation in this case has improved to 80. In transposition babies who have a VSD, there is good mixing. Amount of blood flow returning from the lungs is very high, and because of mixing, saturation is not that low. Cyanosis may be missed, but because of the VSD, extreme chamber enlargement and plethoric lung fields, these baby will develop CCF very early on. On the other hand, if you see if there is a VSD plus pulmonic stenosis or LVOTO, because it's a transposition, amount of blood flow going to the lungs is less, returning from the lungs is less, and this is inadequate to maintain a good systemic saturation. So this is typical tetralogy physiology which you are seeing in a case of transposition. We'll explain that later on. But transposition VSD PS patients will have extreme cyanosis. In total anomalous pulmonary venous connection, there are two types. One is the unobstructed variety and one is the obstructed variety. It may be supracardiac, intracardiac, or infracardiac. Infracardiac TAPVC are usually obstructed. As you see here, the entire output from the lungs returns to the right side and goes back to the lungs. The only source of blood is across this AHD, right to left shunt. So as long as there is good amount of blood flowing into the lungs and getting oxygenated and a large AHD is present and there is no obstruction at any level, TAPVC patients may remain asymptomatic and saturation may be maintained well enough to avoid detection of cyanosis. But the moment there is obstruction at any level, there will be severe pulmonary venous hypertension, which leads to pulmonary arterial hypertension and decrease in saturation with shock, hypoxia, and obstructed cardiac TAPVC. Obstructed TAPVC is one of the real surgical emergencies in pediatric cardiac surgery. Tricuspid atresia is a type of single ventricle lesion, and if you see, there is no connection between the RA and the RV. So blood needs to travel through the AHD to reach the left side of the heart. Now if it's a normally related great arteries with tricuspid atresia, the blood flow has to pass through a restrictive VHD into the PA. So the QP is low. Whereas on the other side, if it's a transposition physiology with tricuspid atresia, blood flow through the PA is more, and this results in high QP. These patients, high QP patients, don't present with cyanosis, they present with congestive cardiac failure, more like transposition physiology. Whereas low QP patients present with cyanosis, just like tetralogy physiology. And another thing to note is, because of total mixing, the saturation in all the other chambers, LA, LV, RV, is the same. The characteristic ECG finding of tricuspid atresia is also a northwest axis on ECG, just like ABCD, because tricuspid atresia is also said to be an endocardial cushion defect. If you did not notice, kindly go back in the video and see that in total anomalous pulmonary venous connection, the saturation is the same in all chambers of the heart because of total mixing at the atrial level. In truncus arteriosus also, there is a common arterial trunk. The PAs are arising from the common arterial truncus. So there is always an unrestricted VHD. So there is total mixing of the blood at this level. Just like in single ventricle lesions, because of total mixing, aorta and PA have the same saturation of blood. In truncus also it's the same. These are usually high QP lesions, truncus arteriosus, and they don't have much saturation fall. It's almost above 85 to 90%. So cyanosis in truncus arteriosus, even though it's a cyanotic heart disease, cyanosis may be missed. So interestingly, the cyanotics can be divided into three main subtypes. One is the subgroup of patients with FALLOT physiology, in which there is a large unrestricted VHD and there is pulmonic stenosis. A transposition type physiology, which is a high QP lesion, like we saw many cyanotic diseases are having increased pulmonary blood flow also. And the Eisenmenger physiology, which is basically lesions which have developed obstructive pulmonary arterial hypertension with reversal of the shunt. So tetralogy physiology happens in tetralogy of Fallot, but also in double outlet right ventricle with VHD and PS, DTGA with VHD PS, CCTGA with VHD PS, single ventricle VHD PS, tricuspid atresia VHD PS, and also in cases of AVHD if they are associated with tetralogy, that is a TET canal. In all these lesions, there is a large unrestricted VHD, there is obstruction to pulmonary blood flow, because of which there is cyanosis. Many of these lesions will also have cyanotic spells. The second subgroup is the transposition physiology. Just like in the complete transposition of great arteries, cases of DORV with subpulmonic VHD, tricuspid atresia, truncus arteriosus, and single ventricle lesions, and TAPVC, unobstructed variety, can have high QP with cyanosis, and this leads to a transposition physiology. Mostly these kids will develop congestive cardiac failure in the initial few months of life. Lastly, left to right shunts and other lesions which we saw in the transposition physiology, if they are left alone, as the natural history of the disease progresses, this leads to Eisenmenger's physiology. Eisenmenger syndrome is development of irreversible obstructive pulmonary arterial hypertension, irreversible pulmonary vascular occlusive disease. So in a case of VHD, that would mean the shunt reversal. In a case of PDA, that would mean shunt reversal. In a case of transposition, also because of high QP, high pulmonary arterial hypertension, it can lead to early pulmonary vascular occlusive disease. A case like truncus arteriosus, which normally would have a saturation of 85 to 90, once Eisenmengerized or develops pulmonary vascular occlusive disease, saturation may drop further. So acyanotic lesions, when they are becoming Eisenmengerized, become cyanotic. But cyanotic lesions also, cyanosis worsens when Eisenmenger physiology starts. So as we see in a case of VHD, before Eisenmengerization, the shunt is left to right. But once severe pulmonary arterial hypertension develops, like Eisenmenger syndrome, the shunt becomes right to left, and this acyanotic heart disease becomes a cyanotic. Surprisingly, if you take a case of VHD only, you will see that a very large VHD, which was having a lot of symptoms, signs of CCF, repeated respiratory tract infections, who comes in failure, if left untreated and develops Eisenmenger syndrome, then the pulmonary blood flow would in fact reduce and the symptoms would improve, cardiomegaly will improve, X-ray will no longer show cardiomegaly, and the lung fields will become oligemic. But remember that Eisenmenger syndrome symptoms may improve. That does not mean patient is operable. That means patient is now inoperable and a surgery would in fact harm him. Now coming to timing of cyanosis, the appearance of cyanosis in different diseases is different. If cyanosis is present in a neonate at birth, most likely he is suffering from some form of atresia, pulmonary atresia or aortic atresia, or an obstructed infracardiac TAPVC, or complete transposition of great arteries with inadequate mixing. These will present at birth. If there is some good amount of mixing in a transposition case, then they may delay presentation by 1 week of life. Also, hypoplastic left heart syndrome may present by 1 week of life. By 1 month, critical pulmonary stenosis, that is TOF with critical PS, DORV with critical PS, and other cases like truncus arteriosus or transposition but with a VHD and good mixing would present by 1 month of age. And usually TETRALOGY and its variants would present by 6 months of age. The timing of onset of congestive cardiac failure. The concepts remain the same. If lesions are present at birth or within the first week of life, they are usually atresias, aortic atresia, pulmonary atresia, or transposition physiologies with very poor mixing, or severe coarctations of aorta. By 1 month of life, a very large endocardial cushion defect, complete AVCD, a very large PDA, or Al-Kappa, they may present by 1 month of age even. By 2 months of age, that is 8 weeks, the PVR has normally dropped down enough, so a large VHD, PDA, the left to right shunts would present by 2 months of age. Lastly, one last slide about single ventricle pathways. So there are a lot of complicated congenital heart diseases which we may not be able to repair and bring up to just like a normal heart, which is a normal heart is a biventricular heart. In those cases, we have to achieve a single ventricle pathway. Like in this case, you can see that there is only one ventricle, and we need that one ventricle to provide a good systemic circulation. So what we can do, the idea is the systemic venous return should not return to the heart. We can directly return it to the lungs. So we do that by doing a bidirectional Glenn operation in which SVC is anastomosed to the PA, and a Fontan operation in which IVC is anastomosed to the PA. So what we achieve is the entire systemic venous return is going to the lungs. Through the lungs, the oxygenated blood is coming back to the heart, and the single ventricle lesion, we make it more effective. The life of the child is prolonged. That single ventricle is used for providing the systemic circulation. So this we have to do in stages. BDG or bidirectional Glenn we do before 6 months usually. Fontan we do usually by 4 years of age. And for achieving this systemic venous return to the PAs, it is very important that the PA pressures remain low. So if we wait till 6 months, there is a chance that patient will develop, because of severe PAH, pulmonary arterial hypertension. So in those patients who are having high QP lesions, you have to do a PA banding, which will restrict the amount of blood that is going into the lungs and delay the occurrence of PVOD and keep the PA pressures low for a future Glenn. Similarly, in those patients who are having low QP lesions and are severely cyanosed, they may not survive till 6 months of age. Also, for doing a bidirectional Glenn Fontan surgeries, you need good size of the pulmonary arteries. So if there is no flow, the pulmonary artery size may be low. In those cases, we have to do a systemic to PA shunt so that blood flow to the lungs continues, saturation is maintained, the child grows up to 4 to 6 months, and also good saturation we are able to maintain. So this is a brief overview about the single ventricle pathway. So thank you for your patient listening. I recommend all of you to read Professor Rajendra Tandon's Bedside Approach to Diagnosis of CHD. It's an indispensable book. Thank you.